Welcome to the Radiate Insights Lung Cancer Roundtable, and the first episode of a podcast roundtable on treatment complexities and clinical insights. This podcast is sponsored by the American College of Radiation Oncology and AstraZeneca. Dr. Brian Lally, president of the American College of Radiation Oncology, or ACRO, will guide the discussion. Dr. Lally polled ACRO members through social media about their opinions on a variety of lung cancer topics. Dr. Lally and our panel members will now introduce themselves.
My name's Brian Lally. I'm a radiation oncologist and vice chair at the Medical University of South Carolina.
Pamela Sampson. I am a thoracic radiation oncologist at Washington University in St. Louis.
Aditya Jaluri. I'm a radiation oncologist at the University of Chicago.
Alex Whitley, a general radiation oncologist in the community setting at Central Alabama Radiation Oncology.
Melina Marmorales. I'm a medical thoracic oncologist at the University of Pennsylvania in Philadelphia.
All right. So what I wanted to do was have a little bit of fun and throw out some interesting questions and just see if we could have some fun discussion about it. I posted them on social media to see how the audience out there responds. I was trying to get as many radiation oncologists to respond. We did get a fair number of responses, and so let's see what they think, and we'll go from there, okay? So the first thing I asked was, in your opinion as a radiation oncologist, what information is most beneficial when discussing stage 3 non-small cell lung cancer with a medical oncologist? Patient performance, extent of disease, molecular markers, or extent of staging? Let's ask our medical oncologist what she thinks we think.
That's tricky. So I think probably people said patient performance.
Actually, it was all over the place. I think people couldn't make up their mind. But as a radiation oncologist, what do we think is helpful when discussing with them?
I think all of these obviously are really good, important things to talk about. I think in the current era, I would make the argument for biomarker status or molecular status. I think we're just at the very beginning of this, and I think it's going to matter more and more as we go along.
I guess the first thing I think about is resectable or unresectable, operable, inoperable.
But I don't think that's her decision.
No, but I mean, that's what I would think about in talking with them. I think this is hey, you've seen them in clinic. They rolled in a wheelchair and pulling oxygen behind them. Okay, we've laid eyes on them. Clearly, their performance status is not operable. So that answered the question independent of extent. That's the first question I have when I talk to my medical oncologist is, are they an operable patient? That's my first question out of my mouth. If they say that, hey, I've got a stage 3 that I need you to see. Is it an operable patient?
I think the most common thing I end up talking to my colleagues in radiation oncology about is extent of disease, because often the question I'm asking them is, can you radiate this, right? If we're considering radiation, I say, in limited stage small cell, is this in a radiation field, or in early stage non-small cell lung cancer, we're considering radiation, is this node that's a little far away? Could you radiate this? Is this something that we should be considering? So I would have picked extent of disease.
That's fair. I get that phone call when it's a stage 3C case. Yeah.
But I would say with modern radiation therapy, there's not many stage 3s that I would say no to.
Agree.
We've got so many different techniques and abilities with gating to limit our OAR doses. We can obviously drop dose. In a large trial, they went down to 54 in that trial in some patients. So we can clearly get a dose in. It's just, is it the best choice and the timing?
Right. Yeah, I think it's that you can, but the nuance is should you?
Right. Well, and if they're an inoperable patient and they're potentially curable, I would say just our sequencing and pairing of it, I guess is what I would say.
Okay. Next question I'll move on to. As a radiation oncologist, what information is most beneficial when discussing a stage 3 non-small cell lung cancer patient with a surgeon? Dr. J, go first.
Yeah, I think it's all about resectability, and we look at technical resectability, medical resectability, and oncologic resectability, and just making sure that we exactly looking at where the tumor is, if it's centrally involving, how central is it, and how close to the airway interface is it, and does a surgeon think that right now, if they went to surgery today, could they resect this patient?
Yeah, I think it's critical. They got to make that decision on day one and never waver from it. Pam, what do you think?
Both of these questions, what I think about is that whoever sees the patient first, whether it's medical oncology or thoracic surgery, it's usually not the radiation oncologist, but whoever sees the patient first, if it's stage 3 non-small cell, load the boat before you do anything, before you cut, before you start a systemic therapy agent. Both hands have to be talking to each other. They are so intertwined now. We can't be making assumptions within reason. As you mentioned, if somebody is on supplemental O2 and non-ambulatory, I think that speaks to itself. But otherwise, it needs to be a team effort right from the get-go. For a thoracic surgeon, I think first should come extent of disease and following the inclusion criteria that were in the studies we have to date, and then closely followed by patient performance status.
Yeah, the audience answered 60% performance, 40% extent of disease. But I do like your load the boat analogy. I'd like to say row the boat, because what we're trying to do at my institution is move to seeing the patients together as a team. They're in one room and all that, but also going a step further and making sure if they don't have PFTs, they're done that morning. If they don't have a PET scan, it's done that morning, or MR of the brain, or cardiac echo. I forget what else they're putting onto the wish list, but they're trying to figure out ways where they set them up the night before, stay in town, and get everything done within 24 hours, especially for those patients who are coming from far away, because we really think it's important that they get that multi-D approach.
I would make a plug for molecular markers in this conversation with the surgeon, because I think in the resectable setting, it becomes more important actually upfront to know the molecular markers.
Okay. So a last question I have is for each of you. Tell me what your definition of oligometastatic disease is, where it came from, and how you're using it in your clinical practice. Why don't we start with Alex first?
I have two different definitions, what I can get approved and what I can treat. And I think kind of following the trials, less than 5 metastases would be my definition of upfront oligometastatic, newly diagnosed patients. But at least in our practice, in our area, getting it approved is kind of 3 or less in most scenarios.
Yeah, I would agree. I think 3 to 5 based on the trials is a good textbook definition for it, but I would just put a plug out for the fact that I think in the modern era of modern systemic therapy agents and how that's going to continue to improve, I think there are many patients with upfront polymetastatic disease with many mets that might end up only having one or a few that remain active on imaging after an extensive systemic therapy. And those are the patients that we might be more keen to consider local therapy on at my institution.
Pam?
One thing I do take into consideration is we should never look at a current scan in a silo. So whenever I receive a consult for SBRT to oligometastatic disease, I'm looking at their back history of PET scans and what has been the velocity of these lesions. Have they waxed and waned? Have they increased in number? Have they decreased in number? I do look at the trajectory of their disease, not just a snapshot in time, to help make that decision with my medical oncologist to see is now the right time to radiate versus going to next line therapy or a clinical trial and keeping radiation in our back pocket.
I totally agree.
I'm going to tell you my answer first because I think it's the same as yours. I have an in-house oligomet study looking at MRD and using that to try and guide therapy. I suppose you're the same boat, correct?
MRD is a great tool here. What I was going to say is that I'm much more a fan of radiation for oligo-remnant disease. I think that if you are able to give the patient systemic therapy and they have a really nice response, that's a great opportunity to consolidate. Clinically, if you're thinking about upfront curative intent therapy, for me, oligometastatic disease is one site. And that's really the only type of patient I would ever consider that type of approach in. And even then, I would consider which site. So one solitary brain met, very favorable. You could go for curative intent extracranially. A solitary liver metastasis, I'm probably not going to touch that. I'm going to give the patient systemic therapy and see how they do.
We are increasingly seeing patients where radiation is co-managing the metastatic disease with their systemic therapy. So I can think of a number of patients I've had where I have over a 2-year period SBRT 2, 3, 4 sites of disease in different areas, and they have been on the same systemic therapy the entire time. So we see it as a bridge to maintain their current line of therapy so that they don't have to pull out plan B, plan C, plan D quite as quickly, because we assume, okay, that one spot popped up, that's just a clone that's resistant, and the drug is working to control the disease in other locations.
Well, and that's getting to the different definitions of oligoprogressive, oligometastatic, oligo whatever, and having trials to justify it, to get it approved.
I do think that biomarkers and MRD and better imaging would just make all this obsolete, because we're trying to put a easy bow on a very complicated situation that can't be answered by number of lesions.
So on that, I just want to say thank you. I thoroughly enjoyed you being here. Hopefully everyone out there in the audience listened and learned something.
We would like to thank our audience for listening to Radiate Insights. We hope today's conversation has provided valuable perspectives for you on the evolving landscape of radiation oncology and lung cancer treatment. Thank you again for joining us. We look forward to having you back for future episodes of Radiate Insights.